Hello, we will be discussing abortions in this session, and we shall be interested that by end of the session you should be able to define the various types of abortion, outline the causes and management each of these types, and then also describe a relationship between abortion and its complication and maternal mortality. We are aware that our viability has reduced from 28 to 26. So any pregnancy losses before 26 weeks of gestation should be considered as an abortion. Sometimes people use this abortion and miscarriage as synonymously, but they should actually mean the same thing. Or in other terms, it's defined as any pregnancy losses in which the fetal weight is less than 500 grams or less. Statistics about abortion is very interesting in that what we call a chemical pregnancy losses are very common among women. Chemical pregnancy are pregnancy where you may not be able to document by an ultrasound scan. So there will be no clinical features. Of course, you test positive, but if you do an scan, it's not there. Sometimes women think they have a delayed period, and then when they have a delayed period, they have slightly heavier bleeding, which could actually be what they call a chemical pregnancy loss. And 60% of that occurs among women of reproductive age. Among the clinical pregnancy losses, up to 15% of pregnancy lost by 20 weeks of gestation. Between 4 to 20 weeks, we lose quite a number of pregnancy. Importantly, we need to know that most pregnancy losses that occurs in the first trimester is related to chromosomal defects. So up to 70%. So when we're doing our investigation, we need to put this at the back of our mind. Remember, 70% of the pregnancy losses are related to chromosomes. And in most cases, when these people come to your clinics, they come to your hospital, you start asking for malaria tests, you ask for syphilis, much as you actually. So let's start applying some of this knowledge in practice. It makes more sense. Abortion has different types. Could be called induced abortion. We look at the different types, how they are defined, and how you can make a diagnosis of them. It could be a threatened form of abortion. This threatened abortion can progress to inevitable abortion, then ultimately to incomplete or complete abortion. When the products get infected from inside, we call that septic abortion. And then when the fetus die from inside, we call that a missed abortion. But sometimes when pregnancy is lost frequently, we call that recurrent abortion. For induced abortion, we need to have we need to know that it's an intentional or medical or surgical termination of pregnancy. This could be elective where the woman chooses to terminate the pregnancy, or it could be therapeutic where, because of medical reasons, the mother needs to be terminated. Induced abortion is allowed only for medical indications in this country. So we need to appreciate that, yes, we need to avoid as much as possible getting involved with the law. The law has a long hand, it can catch you. It's only done if continuation of pregnancy put risk the life of the mother, or if the baby that is a fetus that is inside has severe congenital anomalies that is incompatible with life. We need 2 medical doctors to decide over this, and this is we know it's not a common practice that 2 doctors have to decide. And we also, this has a reputation that we need to appreciate elective abortion is unlawful. Induced abortion has complication, and the complication could be because of a number of things. It could be because the abortion is done in a clandestine practice. That means it's done in hiding. It is done in hiding, and this end up being unsafe. Unsafe abortion is a significant contributor to a maternal mortality in our country. It could also lead to perforation of the uterus. It can also get other visceral organs can actually get involved, like the intestines. Sometimes the bladder is perforated because of the instrumentation that is being done to terminate the pregnancy. It could lead to severe hemorrhage, leading to hypovolemic shock, and then heart failure or anemia and heart failure. This can actually cause a maternal death. Can also lead to sepsis and other associated complications related to sepsis. Sometimes when the uterine wall filled with a lot of scarring, it results into what we call Asherman syndrome, and that may cause infertility in the subsequent trial of pregnancy. A threatened abortion refers to a stage in the abortion process that suggests that there is possibility that a mother can miscarry or not. In this case, most of the mothers present with minimal or no lower abdominal pain or cramps, and they normally have a slight vaginal bleeding and sometimes minimal amount of liquid draining. So when mothers present with slight symptoms like this and they're pregnant, we consider them to have abortion. Most of them, when they do examination, they're actually stable. Then the fundoid may actually correspond to the gestational age at that time, and in most cases, the cervix is still closed. What do we do for such kind of mothers? One, we need to have them bed rest, then avoid strenuous exercises, and then we can also give tocolytics. Tocolytics are medicine that helps to terminate uterine contractions. We may also consider doing pelvic rest. That means that they should avoid sexual activities for that time. Sometimes threatened abortion progress forward to become inevitable abortion. In this case, there's no way the pregnancy can actually stay. The woman will the process of miscarriage will continue and resulting into a pregnancy loss. Inevitable abortion presents typically with moderate to severe vaginal bleeding. There will be severe abdominal pain. If the membranes already ruptured, there will be significant drainage of liquid that is seen. Of course, if you do examination, you find that the cervix is normally dilated with evidence of imminent expansion of product conception. So you'll be able to feel product conception in cervical also. You find that the fundal height corresponds to the gestational age by that time, and then you'll be able to feel uterine contraction. The management for this kind of case is that you need to do evacuation, but of course some mothers prefer not to intervene. So you need to, if the bleeding is much, you need to do something. If the bleeding is not much, probably you can do expectant management. But of course you need to have blood grouping and cross matching because of the nature of bleeding. And if for advanced pregnancy, you can actually augment with oxytocin. And if there's some product of conception, you may need to do evacuation, and that's ready to complete abortion. This picture is, I put it here just to show you what can be used to evacuate the uterus. And this can univalve vacuum, manual vacuum aspirator. But as you're aware, we have a number of these things here with us, number of the bivalve vacuum assisted manual vacuum aspirator. For incomplete abortion, some product of conception already expelled, but some of them actually retain in the uterine cavity. These patients present typically with moderate to severe vaginal bleeding, and they still have cramping and then abdominal pain, and then also they will tell you they already expelled some product conception. If you do examination, you find out that the uterus is smaller than the dates that they have really given you, and then the cervix is normally dilated. What do we do in these cases? One, we need to actually manage the incomplete abortion by resuscitating these mothers, especially if they have lost significant blood. We may need to do blood grouping and cross-matching, and then blood transfusion if we think it's actually they're in hemodynamic instability or their blood significantly becoming anemic. We may need to consider doing evacuation using manual vacuum aspirator, especially if it's less than 12 weeks. But of course, I think the world has moved now. We have MVA that can evacuate up to 16 weeks. Although it's not yet in our local market, but I think very soon we should be able to have them. We may need to consider giving antibiotics and then pain medication. It's very key. Septic abortion is when the product of conception is actually infected. Normally, this patient presents with fever, abnormal vaginal discharge, and then abdominal pain. If you do an examination, most of them present with signs of very sick-looking patients. They normally have jaundice or they're having fever. They have tender uterus. They normally have offensive vaginal discharge or bleeding. The cervix usually is soaked, and then probably find that the cervix is dilated. Complication of septic abortion can be many. It can be immediate, and then it could also be a late complication. The immediate complication of septic abortion could be hemorrhage, can also be peritonitis, pelvic infections, septicemia, septic shock or hemorrhagic shock. And then the late complication, of course, we need to appreciate that secondary infertility because of asthma syndrome is common, can also cause chronic pelvic pain, and then pelvic adhesions, and then ultimately recurrent post-PID, pelvic inflammatory disease. How do you manage a septic abortion? You need to resuscitate them. We need to insert those for monitoring of urine output. We need to put them catheter. We need to do blood grouping and cross-matching for any eventuality. If there is septic shock, we need to give blood. If there is hemorrhagic shock, we need to give blood. The antibiotic of choice, of course, you need to consider that. And then we need to ultimately do an evacuation. And at discharge, if they are anemic, we need to consider giving them hematinics. I want you to go and read about recurrent pregnancy losses. Sometimes it has very many names. It has names like habitual abortion, habitual miscarriage, recurrent abortion, recurrent miscarriage. So read, summarize the major causes of recurrent pregnancy losses, and then we'll discuss that tomorrow in the class. So make sure you read, you summarize, you do that. You'll again discuss it in a group and then present it in the class. So the other thing that I want you to go read is that you need to read about post-abortion care. You need to define post-abortion care. You need to explain why counseling should be integrated throughout all components of post-abortion care. So I want you to come out with all this. And then you also need to outline the 3 components of post-abortion care model and the main elements of each of the models. So I want you to draw a conceptual map of the post-abortion care model. You need to define the difference between emergency obstetric care and post-abortion care, and then also give us the benefits of providing post-abortion care services, especially in our setting here. So basically that, when we meet in a class, these two questions, these two sets of questions, you should be able to discuss before you see me, and then we'll discuss as a group in the class. Thank you so much.